Okay, welcome everybody. We have restarted recording as the first part of the session will be a bit of an update from Lucy around the MHCLG updates, and then we'll go into a bit of a update from Bournemouth on some of the work that they've been doing around bloodborne virus testing and their pop-up Hep C screening clinics. So we will record this section of the meeting, and then after that we'll stop the recording when we go into a bit more of a general meeting. But welcome everybody. I won't delay things any further, and I will hand over to Lucy, if that's okay. Lucy, if there's anything to update from an MHCLG perspective.
Yep, good morning everyone. Hi, my name's Lucy Baker. I'm a Rough Sleepers advisor at MHCLG. That's an embarrassingly empty slide, and I do apologise for that. We have been very heavily involved with local authority areas in co-production exercises regarding their potential bids into the Next Steps accommodation programme, which I've talked about last week, the deadline for which is the 20th of August. So things are hotting up, and we are in a great deal of discussion with various areas about that. So that's an ongoing current, priority piece of work. In terms of an update that might be useful for this group, yesterday, updated guidance for commissioners and providers of hostel services for people experiencing homelessness and rough sleeping was issued on the .gov website. I will post a link to it in the chat. It's well worth a read, talking about people who may become symptomatic and what to do in meeting the overall sort of health and wellbeing needs of residents in hostels in response to COVID. So I'll post that in the chat, and hopefully that'll be helpful. And apart from that, that's my updates, I'm afraid. If anybody's got any quick questions for me, then please go ahead.
That's brilliant. Thanks, Lucy. And Claire's going to touch on that guidance as well when she speaks later. So that's
Great.
brilliant. It's been long overdue. But any questions for Lucy in the meantime?
If not, then just a reminder, I'm sure you are all very well aware there's a heat wave pending over this weekend. And of course, thinking about what your additional response to rough sleepers will be during that hot weather period.
Brilliant. Thanks, Lucy. Fab. Okay. That brings us on to our guests. Just introduce Hazel and Karen from Bournemouth and Christchurch and Paul. Welcome, Karen and Hazel. I won't do any major introductions. I'll let you guys speak, but welcome and thanks ever so much for taking the time to come and chat to us about your work.
Thank you. I'll make a start. So I'm Karen Wood. I'm the Commissioning Manager for BCP Council for Drugs and Alcohol, and then I'll hand over to my colleague Hazel, who's the liver specialist nurse from Royal Bournemouth Hospital. Just to give you some quick background before I let Hazel take over, because you're more interested in what she's done and how she's done it, is that Hazel and I have been working together probably for about 15, 16 years now, where we, about 15 years ago, introduced a community to hospital Hep C pathway, which we've been delivering since then, tweaked it a couple of times over the years, but it has been a really, really good partnership approach to testing and treating people with Hep C. From that, last year we decided to put a bid in for some additional small bit of money to do some testing for the wider population. And this is the population that isn't in treatment in the Pan-Dorset area. So we were also covering our colleagues in Dorset County Council as well. That partnership working in that partnership bid was a multi-agency partnership between the two local authorities, the Royal Bournemouth Hospital, our local drug and alcohol service, Homeless Health, and also the Hep C Trust. We were very successful with that bid, which was looking at testing and treating the wider population. And from that, we've now got very close links with Gilead and the NHSE coordinator as well, who have been instrumental in helping us pull this together. We were due to start our wider population pop-up clinics, as we were calling them, in April, but because of COVID, that kind of ceased. Hazel and I got back in contact with each other around about mid-May and thought that we were in a golden opportunity with all the homeless people being housed to actually change our bid slightly and actually then concentrate on them. So we then applied to NHSE to change our bid slightly. Our original bid wanted the wider population in the summer. We could do that in markets and other locations, near the beaches and things like that over the summer period. And we were going to concentrate on the homeless periods. So we've turned our bid upside down now. So we've gone out and we've actually tested within hotels. Hand over to Hazel now, who can tell you in detail about how she's done and what she's done as well.
Sorry, just one of my computers that I was going to be referring to just decided to switch itself off, so I apologise. Hi, so as Karen's kindly introduced me, I'm a consultant nurse in liver disease for Dorset. We're based at the Royal Bournemouth Hospital, but we have a remit across Dorset for hepatitis B and C. And I've been in the post for 23 years, and we've delivered care for the west of Dorset through Dorset County Hospital in Weymouth, in Poole Hospital, and also was originally 4 male prisons, but now we're down to 3 male prisons in Dorset. And until recently, we were also doing community clinics, which were based in a drug and alcohol service, a homeless drop-in service, but all those had to stop when we hit COVID. And as Karen said, we had a plan to widen our reach to reach the homeless a bit more, but also to reach the wider population, people that have maybe been exposed to hepatitis C years ago, have been clean for a long time, people that may have caught it through a blood transfusion. But as Karen said, we were faced with lockdown. We didn't treat anybody for a couple of months. We were basically all locked down and working from home. And then I was made aware that we brought in nearly 300 individuals into temporary accommodation, emergency accommodation because of COVID. And these were a lot of the people that we've been trying to engage with for a long time. So we just said, look, this is a massive opportunity to treat the homeless, who are hopefully going to be a bit more stable because they've been brought in. And actually, we decided very quickly that that's what our focus would be. We didn't know how long the temporary accommodation was going to last. We were worried that actually if we didn't act quickly, people would start to go out, and they are starting to go out, but actually BCP are very committed to keep as many people in as possible and to change the way that we're handling homelessness across the new council area, which is Bournemouth, Christchurch and Poole. And that's developing and looking really, really good. So we're hoping that actually the work that we've been doing can continue and work alongside that provision. We're looking at healthcare provision, which is going to be mobile and around the area. So we're working alongside that. But obviously what we were facing with is a lot of people that we've been trying to engage with for a long time. All of a sudden they're in and they're hopefully going to be more stable. And actually it was proved that a lot of them did become more stable with being brought into accommodation. And in the accommodation they've got housing, St Mungo's, which is our rough sleepers team, health provision including us. So a lot of wraparound services and everyone working together in a hub style, which is what we'd always been talking about, but all of a sudden all the barriers were being broken down and we were doing it. So going back a little bit, I don't think that we could have acted so quickly and turned our service round so quickly without a history of close partnership working that Karen alluded to. And having a passionate team, including a worker that has been employed from the Hep C Trust, Hep C Later coordinator, bloodborne virus nurse, my team, Karen and Sarah, her colleague from the commissioning team, public health. These people were already people that we had good working relationships with. So we're able to turn things around very quickly. They had a very can-do attitude, problem solving. It was like, let's just put this show on here. There was no sort of issues about, oh, we can't do this, we can't do that. It was more about how can we do it. We had shared goals. And the other thing that we had was very excellent managerial support, freedom to act and be reactive. My management were very supportive. There were issues because even now, as liver nurses, we are not able to see people face to face unless we have a good clinical reason why in the hospital. And there was me saying, I want to go out and see people face to face right now in the middle of a pandemic. And because we have very good, all of us have, I think, excellent managerial support, although there were concerns, they were happy for us to pursue this. And they could see that it was innovative work that we were trying to do. But we did have to act quickly. We had to put a team together. We had to decide what our priorities were, which again, we were looking to target those people that had been brought into the hotels, and we needed to get out quickly before they started being moved. They were moved on to more stable accommodation, or they were going out because of various reasons. They chose to leave, or there were issues with their behaviour. So we knew that we had a window of opportunity. So I had to look at PPE, not something I've ever come across before. I had to write a standard operating procedure very quickly. We had to look at making sure that we were safe, but also the people we were coming across were safe, because we were probably more of a risk to them than they were to us, because we were working in the hospital environment. And I can share that standard operating procedure. But as you can see from the lovely picture of me, it involved wearing mask, visor, and when we were testing, obviously wearing aprons as well, and having a cleaning procedure between patients. We asked the patients to put masks on. They had to put gel on their hands beforehand, and we were very careful about trying to avoid any risk of infection. What we offer, I think, as a team is a very friendly, non-judgmental, flexible service. It's neutral, it takes away the stigma. We turn up, we test. It's very, very open to the client group. And I think they really, the feedback we had was that they really appreciate that we were coming to where they were. And that's one of the big things. It was about taking the service to them. We also very quickly looked at our pathways and tried to break down a lot of the barriers that we have always had in place, because, as I say, I've been in this service for years, and it's been a very medicalised approach to treating hepatitis C until now with the new DAAs. So we've simplified our pathway, we've demedicalised it, we've removed the barriers, and we've prioritised viral clearance over assessing fibrosis. So I've been doing just assessments by talking to people to say, is this person likely to have a high or low risk of cirrhosis? We're using that to MDT them and decide what medication to use, but we're not necessarily scanning everybody or getting a fibrosis assessment right away, because what we want to do is just get them onto treatment, and we felt that was our priority. We will go back and we will try and go back and catch everybody and take our FibroScan around and scan people. In the clinic that we did most recently in Weymouth, we were scanning and testing, and that would be the ideal model. But to begin with, we were literally going into the hotels and testing, and I was talking to anybody that I thought was likely to go forward for treatment. So it was a very, very quick turnaround. It was a quick assessment. We used the Aura Quick testing, but we didn't use dry blood spot. We didn't use oral swabs because they take a while to cook. You have to worry about whether they've cleaned their teeth, if they've been eating, whether they've had a cup of coffee, and we really didn't want there to be too much for people hanging around. So we used the Oral Quick, but with a blood spot, so a drop of blood into the mixture. And as soon as that had cooked, if they were antibody positive, we went straight to do a dry blood spot test. And initially we were just sending them for a straightforward PCR, but we have now set up an agreement with Birmingham, and we're now doing dry blood spot testing, including genotyping, so that we're not using up all our pan-genotypic 20% too rapidly. Although to begin with, we were just going out and getting a basic PCR and treating on that pan-genotypically, and that's what we've done up until now. We've only just started using the Birmingham laboratory. So we went into a number of hotels. We also went into some of the hostels and some of the supported housing provision, and that was led by the colleague from the Hep C Trust, the peer mentor support. Her name's Tash, and she went in and basically arranged quite a lot of extra stuff over and above the hotels. We had good support from the hotels. We had a good support from the BCP, not just Karen's service, but also the officers, the housing officers, to help us to get access to the hotels and for us to be allowed to go in there, which was excellent. And oh, my computer stopped again. That's really irritating. I'll tell you the numbers in a minute. So that was what we did initially. I would say that was mid-July to the end of July. And then we've now wanting to go broader into Dorset. And a lot of the places that we could have gone, we can't now because of some issues with suitability of going into locations because of COVID. Places where we would have gone might be somewhere that people are housed. They might be other healthcare provisions where they don't really want people coming in because they may well still not be doing face-to-face. So our next bit of the plan was that we wanted to get mobile. I work with Liver for Life, which is a liver charity, and they have a bus which they bought to try and do some awareness work, but it basically was parked because of COVID. So I talked to my colleague Richard Hall, and we've basically agreed to hire the bus, and we're now going out with a bus and gazebos and trying to see people in the fresh air, test them in the fresh air, but use the bus for fibre scanning and examining, and for me to see them to do an assessment. So it's a one-stop. They come, they be tested, they're assessed and fibre scanned if possible, if there's time. And then the next time we see them, which would hopefully be a 2 to 3 week turnaround, which is the sort of turnaround we've been using, then we go back and start them on treatment. We went to Weymouth on the 23rd of July and we did a pop-up clinic. We saw 25 people, 13 of which we dry blood spot tested, and we're waiting for their results to come back from Birmingham, and we hope to go back next week to see the people that need treatment and hand out their medication, but also to test some more people. And that's the sort of timeline we're working at now, and we're hoping that we will be able to go out and do this across Dorset, but also use the bus around Bournemouth and Poole as well. The other thing that we've done is used incentives. I was a little bit I needed to be convinced about incentives, but we used the anonymous survey, which came with a voucher for £4, and we used it when we were going to hotels, and we found it was good. People were coming because they just wanted a voucher. So we got some money from Public Health, and we got some Love to Shop vouchers for £5. And we used them in Weymouth, and we know that people were definitely towards the end of the day coming because they'd heard in town that there were some people in a car park handing out vouchers. All you had to do was go and have a Hep C test. So we've actually incorporated that in our plan as well, and I have put in revised costings to pay for the bus, to pay for the ongoing testing that we're talking about, and to also continue to use incentives. It's been an amazing piece of work. It's been very collaborative. It's been exciting. I've been in this job a long time, but you know, it's been fun and it's been very enjoyable. And I'm just going to start this computer again to give you the numbers because it keeps logging me out. So 1 second.
Just while Hazel's doing that, just to say that one of the things that we did was a week before we went into each hotel, we made posters. So we put them up in all the community areas. We put the leaflets under every single person's door just to highlight the day we'd be there. Each hotel has a support worker, and they've also got security guards. So we briefed the security guards and the support worker the day that we were coming in. So they kind of encouraged people not to leave the hotel until they'd actually had a test with service, and that worked really well as well. So, you know, it was, as Hazel said, a real good partnership approach and a collaborative approach to actually trying to get the people most at need tested.
Yeah, my colleague, I have a colleague that we have this amazing setup where she is a homeless health nurse 2 days a week out in the community, and sorry, the other way around, 3 days a week, and then 2 days a week she works with me within the Hep C team, and she has been an amazing link and basically you know, seeing people on days when she was out doing a homeless health and also working with us, and as Karen said, they were putting leaflets in people's breakfast boxes when they were coming in. Everybody was aware of what we were doing. So just to give you an idea, this is some figures that we put together prior to a meeting on the 17th of July. And at that point, we had seen and tested 131 people. We'd done 56 dry blood spot tests on the back of people being antibody positive. And we'd started 27 people on treatment. Now, we've actually been to Weymouth since, I mentioned. We saw 25 people there, 13 people we did a dry blood spot test on, and we're waiting for those results to come back. I don't think all of those will need treatment, but I think the large majority will. And up to this point, we've treated 32 people. And I've been off for a week and a bit. My colleague, the nurse I just mentioned, who works in homeless health, is off this week and was off next week. Everyone's off on holidays now, so I think we've done well to treat that many people. The only thing I didn't mention was we also did invite people that had been lost to follow-up that we knew were already antibody positive but hadn't managed to engage in treatment to come forward. So some of these people that we've tested, we did already know they had Hep C, and it was another way of engaging them. And then the other thing is that we did test a few people that were post-treatment. So not all of that 131 were brand new people, but quite a lot were. And the thing that my colleague Chrissy said was we were doing these clinics in the hotels, in the hostels, and she would get very excited about certain individuals coming through and sitting down and talking to us, because she would say, oh my goodness, I've been trying to engage these people for years. I've never got them to sit down and talk to me. I've never got them to have a test. And I certainly never got them talking about treatment. And we've met people, myself and Chrissy, who we've met in the past, and we're seeing them now, and they look like different people. They're eating, they're sleeping, they're getting their health sorted out, their mental health is better. And it's windows of opportunity. It's catching them when you can treat them. Okay, they might fall off the program later. They might go out and reinfect themselves with Hep C, but we know that there will be a peak of reinfection with trying to eliminate hepatitis C if you look at how they plot it. But in a way, you don't have to worry about that sort of stuff. I think you just have to get out there and treat and test as many people as possible. You have to treat as many people as possible to get your residual infection down quickly. Otherwise, you're just going to be whack-a-mole. You'll be treating this person over there while someone else pops up over here. You have to try and treat people quickly, otherwise you won't achieve elimination. And that's why I think this sort of quick approach, really just treating the virus, worrying about the liver and the level of fibrosis sort of afterwards or during, and just and we are hoping that we can take these services around to different more rural locations, because we've got the whole of Dorset, which is a massive county with lots of rural areas. But say we're hoping that we can go to, say, Blandford or Shaftesbury, turn up, try and treat as many people as we can over a few months, do a micro elimination, and then move on to the next place, and just keep going round until we're really impacting the level of Hep C in our county. Right, I think I've said enough. Thank you.
That's fantastic. Thank you, Karen, and thank you, Hazel. It's amazing. I'd love us to be able to do something like that across the whole of the South East. But I'm not sure, Sharon, if Hazel's answered your question completely. So there's a question in the chat box about would it be possible to share the metrics you use to track and assess improved health? And you touched on the metrics in terms of the the program itself. But did you do anything around this assessing overall health at the beginning when they came and chatted to you, or was it just purely around the Hep C? And have you kind of tracked that through, or have you got any plans to do that?
So I can talk about what was happening broadly, because, as I say, my colleague Chrissy works in homeless health. So she, along with a GP that does homeless healthcare, they both went from doing face-to-face stuff to being at home. And we initially, what we were doing during lockdown is we put together an assessment that was a general health assessment, but also Hep C assessment, and they were doing everything at once. The GP was doing it, Chrissy was doing most of it. It was mainly around our homeless health and an opportunity to do a really good health needs assessment on everybody, but it included hepatitis C. And that was just a good use of their time during lockdown. And it was felt that it was a great opportunity they were having their housing needs assessed, their social needs assessed, they were also having their health assessed. But as we started to crank up and start to do our Hep C work, we then concentrated on a very specific Hep C assessment. And actually, I've been paring down the assessment to really just gather the information that I need so that we can turn people around quickly. But I'm happy to share all the different iterations of those assessments, and that's a wider piece of work that we're involved with, but we haven't been assessing their health in a broader way just through this system. But we are gathering quite a lot of data. We have a list of data that we're gathering, and we haven't managed to crunch any numbers yet, but again we could share with you the data that we're gathering. We started off by taking this information verbally as they were coming through, but it wasn't working very well because they were coming through so quickly. And when I looked at some of the pieces of paper that were left for me at the end, all they had was the person's name on the top. I didn't get any real good quality data about demographics. Had they been tested before? Were they involved in drug services? Had they been in prison previously? So we decided that actually, if we were going to give them a voucher, there's no reason why they couldn't fill in this information themselves. So when we went to Weymouth, we bought some clipboards that were wipeable and pens, and we basically said, right, you sit down, you fill in this questionnaire, we can help them if there's an issue. And the questionnaire is then passed over, and the last page of the questionnaire is the testing bit, where the nurses recorded what testing they'd been done. And then we had a separate piece of paper, which was the pre-treatment assessment that I would do on anybody that was antibody positive that we were doing a dry blood spot test on for PCR, that we knew that we probably would be treating. So that all the people that were seen in Weymouth, all that's been done. So when we go back, I can literally hand over the medication, and it's just a two-stop process. So again, I could share that with you. So when we went to Weymouth, we have 25 lots of good quality data that we can easily crunch now and feed back. And I think that's it's the best use of everyone's time. It's the most likely that they will use it. And then they'll sit and fill it in. And that's what I saw with the anonymous questionnaire would make your head spin, the number of questions, but they sat there and they filled it in for a £5 voucher. So our questionnaire is a lot shorter, but it means that they can be doing that while we're concentrating on the testing. We get the data, and they're more likely to probably answer the questions a little bit more truthfully because we're not stood over asking them questions. So we are gathering quite a lot of data, but not the broader health assessment. We've sort of split off, and that's still carrying on, but that's mainly through the homeless health provision.
That's fantastic. Thank you, Hazel. Are there any more questions for Hazel and Karen? I just got a quick one. It's probably for Karen around funding and whether you had to, you've talked a bit about your kind of partnership approach and how that's helped and things, but did you have to kind of build a strong business case or anything in terms of this, because testing treatment can sometimes be quite expensive around Hep C, and were there any kind of barriers around kind of making any of this happen in relation to getting the budgets and the funding together for this?
No, it was fairly easy because within the public health grant, I have an allocation for dried blood spot testing, and because of lockdown, we hadn't used that. We've just used a proportion of that for this, but we also were very successful in our bid to Gilead, so we got £15,000 from them to actually undertake this with the homeless population as well. So with the mixture of the public health grant funding and the Gilead funding that we've got, that has managed it, and then the goodwill of all the partners. Hazel and her team have done it as part of their normal role, and the same with the people in the drug services. They've gone out and done it as part of their normal role as well.
And do you think, because obviously you're looking at expansion and things like that, do you think that having now done this, that'll help you be able to get further funding should you need it going forward if you do want to expand?
Yes, definitely. I mean, we're looking at if the next round of bids from Gilead come out, putting in another bid. I have found in the past it's easier to get smaller pots of money than get a larger pot of money. So we put in a 15,000 bid, and within a couple of weeks we got told yes, we were going to get that funding. We'll try again for a smaller pot of money again, and it's just putting in small bids wherever possible. But the BCP Council are very much behind what we are doing and can see the benefit of this for statutory services, because if we can get somebody treated now and they don't go into long-term liver damage, actually the costs to the statutory services for health and social care are huge.
Absolutely, that's brilliant. Thank you.
I can add a little bit to that. So you know that we are getting money from NHS England, £500 for each person that we treat. So that's a budget that took a while to come through, but basically we haven't spent very much of it purely because of COVID and everything locking down. And I must have written my budget on how I was going to spend it about 4 times now, because it keeps changing. The plan was to have a full-time band 6 nurse and a full-time band 4 care coordinator. We've put the care coordinator to one side. One of the main reasons is just office space. I mean, it's crazy, but there's so many things you've got to think about now. And also, I just wanted to spend the money slightly differently. So a big part of that budget is paying for the oral quick swabs, paying for the dry blood spot testing through Birmingham, which is new testing, because if you send it along to the virology lab, you don't get a definite bill. It just goes into a massive pot. But if you want to do dry blood spot testing, it's all of a sudden a completely separate cost. So I've costed for the oral quicks, I've costed for the dry blood spot testing through Birmingham, I've costed for a full-time nurse. We don't have that provision now, but it's coming. And I costed for hiring the bus and just all the stuff that we need to do that. And Public Health have kindly already paid for £250 worth of incentive vouchers, but I've put that into my costings as well, that I want to be able to use them. So I mean, if you work it out, it's about 120 quid for the dry blood spot test, or I can't remember exactly how much it is for each oral quick. Then you give them incentive. But if you treat that person and get £500, you're not taking that much out of that £500 to turn them round. And we've got an opportunity that the more successful we are, the more money we get, the more we can grow. So the cleverer you can be. So I think you've got to speculate to accumulate. I know that sounds a little bit but that's basically what. So I've very recently done a new budget, and again I could share that with you about how I've broken down how I'm going to spend my money, because I think I do need to keep going back and saying I know that I've got this pot, but this is why and how I want to spend it. And as I say, I've had to redo that 2 or 3 times. But now I've done it and everyone's in agreement, then we can just crack on and carry on doing this work, because we've sort of pretty much worked out what we want to do. We're not going to have regular clinics in drug services. We're not going to go to a lot of the places that we were going. 1, because they just can't accommodate us, and 2, I can't commit staff to the same place every week between a set time and a set time, because that's very tiring. I much prefer this. Let's just pop up, do it, sort out this lot, go on to the next place. And I think that's how we'll work. And we may end up working like that long term, but certainly while we've still got the pandemic, that's the way that we're going to work. So we've really changed our approach, and I think this is going to be more effective, but we'll see.
Sorry, struggling to get myself off mute. That's brilliant. Thank you ever so much. Last call. Any more questions before we move on? No. Thanks ever so much for joining us. That's really good to hear, and some fantastic stuff for us to think about over here.